Hi everyone.
Last couple of people joining. So we're recording this so you can kind of have a look at it later if you want to. So I hope that you're all here for the ultimate kind of guides to your foundation job in general surgery. If you want to go to the next slide, Frank. So, so today we've got Dr. Frank Hartley. Thank you so much for coming. So he's a current foundation year 2, but is well done and accepted to core surgical training with kind of an ENT theme. With 6 months in plastics, a year in ENT, and then 6 months in Max Fax. He's had 2 different rotations in general surgery, so he's definitely an expert in the area, and also had TNO and obs and gynae, and passed the MRCS Part A in foundation year 2. Well done. So a bit more about Medics&Me. So how can we support you as incoming F1s, F2s, and how can you get involved? So we have loads of teaching opportunities. We're a nationwide charity. We work all over the country with aspiring medics, current medical students. I think you're starting to come back. And we're really trying to kind of build community and help at every single stage of the process into medicine. So we've got lots of QI projects and research, which is very important, as I'm sure you're aware, in kind of foundation years. We have the careers blog, and all of these are going to go up as blog posts if you want to go back and have a look at in the future when, say, your gen surge job is actually it's the 3rd rotation. By the time you've got there, I'm sure you've forgotten the finer points. So you can go back, have a look. And if you want to, we really encourage people to come and be with us, be a mentor, and really get involved. So on that note, over to you, Frank.
Thanks very much for the introduction, Rhiannon, and welcome, guys. I hope you have managed to avoid the heat a little bit today. And hopefully, we're just going to go through a bit of stuff about being a Gen Surg F1 and how the sort of important things that you need to know and what not to miss, I guess, as well. And I think the main thing about all F1 jobs in general is that it's it's quite daunting and it can be quite scary when you're starting. But the main thing is about being safe, escalating when you're worried or you feel you're at the edge of where you feel comfortable. So just making sure that you are aware of where that is and how to escalate really is the main things that we're going to cover. And then we're going to talk about a bit about some knowledge that you guys can go away and learn before you start that will really make you stand out and make you have a really good time when you're on Gen Surge, I guess. And then we'll talk a bit about opportunities and portfolio, and then some stuff that I did when I was sort of thinking about because I knew that I wanted to apply to CST, but that will help you if you're applying to anything. So I think in terms of expectations of F1 on the job, I don't know how much experience you guys have had of Gen Surge so far, but I think it's probably the unit that I've worked at and pretty much talking to all of my colleagues, the list is the main thing. The whole unit's run off a list. So that'll be a list of all the patients admitted under general surgery. Usually it can be split up into subspecialties, so upper GI, HPB, the colorectal, or it can be split up by consultant as well. But essentially, as your F1, you're mainly focused on the ward. Obviously, you will probably have some on calls as well, but the main thing is the ward, making sure that the ward runs efficiently, essentially. And they can be quite fast-paced jobs, and the consultants often, unfortunately, have other priorities as well. So, they might be doing a ward round before a clinic or before a theatre list, and therefore that means that your job is to make sure that their sort of ward round and everything runs efficiently. And the best way to do that is to make sure that the list is up to date, has the right locations, and often I'm afraid this is like a long Word document, so it doesn't update automatically, and that can be quite tricky sometimes. So you need to be making sure that the locations are all up to date, the patient information is all up to date, and it has key information on it that will make it so much easier when the consultant asks you a question about the patients. because that will mean that it's right at the top of their mind, and you've got a printed out version of it, and you can also give it to the consultant, and that just makes everything run a lot more smoothly. And it's really your responsibility to make sure that when patients are discharged, they're taken off so that you're not trekking to a different ward, for example, for a patient that you thought was still under shared care, and then you're going to have to walk 20 minutes to realize that actually the patient's already been discharged. So that's a really big thing, to make sure that that list is up to date. Then on the ward round, that'll be a daily round for pretty much everyone in general surgery gets seen every day, usually by a consultant or senior registrar. And I think that as an F1, you're mainly sort of scribing, but I'm going to come on to a bit about what's important that you do that often the other teams and sort of more senior doctors maybe don't check up on quite as much. And I think in order to make that as smooth as possible, it's about knowing the patients as well. So, obviously that's not easy when you first start, but as you get sort of first a bit more into the job, you want to know who's admitted under your consultant, know a bit of history about them, what operations have they had, how long ago was it, and that sort of leads on a bit about your sort of background knowledge as well. So I think for that, it's really important to have some knowledge of investigations. No one's going to expect you to read a CT on day one, but to know a bit about why you might order some different tests for different situations just means that you can have, it will definitely make your life a bit easier as you go through. I think in terms of the investigations, obviously that you'll pick that up as you go along, and the best way to pick that up is really to ask. So, when a consultant says this scan needs to be without contrast, or an oral contrast meal, or the CT needs to be done after 4 hours, then you need to. It's so good, and consultants will also love it if you ask why, and they'll give you the answer. That means that they'll give you more teaching, and you'll get so much more out of it. And following on from that, basics about the sort of procedures as well, and surgeries that are done under each subspecialty. And then the main thing about being an F1 is about being safe. And that often means, starting some initial management if a patient is unwell, but mainly that means telling someone more senior who's going to come and make a sort of final plan for it. And then often you'll be asked on the ward round to sort out and coordinate investigations. So I'll come on to a bit of sort of tips on that as well. The main thing, the daily ward round, really, this is a Royal College of Surgeons tool, but I think the main thing is ward rounds, particularly at the start, will feel very fast paced. I've seen consultants see patients in about 2 minutes, and you think, how on earth have they actually seen a patient in that time? And obviously that's not the best practice, and particularly at the start of your career, everything will just take much longer than that. But at the same time, they will be fast paced, and I've worked in a hospital with paper notes the whole time, so keeping up with a consultant, that's moving around the hospital, and whilst on paper notes is not easy. But what I would say is the main things are, it's not quite the same as a medical ward round where there's long sort of in-depth discussions about lots of different points in the plan, and the plans are often 15 different steps, and they take ages, and there's lots of investigations. They're a lot more simple than that. But the main thing is, what have they come in with, what operation have they had, and how long is it since they've had their operation? Those are like the sort of simple history. Then you want to add any sort of new development. So have they had any bowels opening, any new information since the last review? So that's normally, if that'll be yesterday, or if it's been over the weekend, that might be on Friday, or if they were seen over the weekend as well. Then you want to document their observations. I normally it depends, obviously, if you've got an electronic system, it normally documents the observations for you, but you want to make sure that you're checking them, because they can often be the first sort of signs. of deterioration. So you want to make sure, and it's also a really good point to make sure that your consultant knows about the observations of this patient. Then any new investigations that have been done since yesterday. And then these are the sort of things that it's really important that you check. And sometimes the consultants don't always check them for every patient. So it's kind of, that's where it kind of falls to you to say, have they opened their bladder? Have they opened their bowels, and what's coming out their drains? And those should all be documented in the ward round entry. And then eating and drinking. So what are they eating and drinking at the moment? Are they nauseous? Are they still vomiting? All of that is really important to be documented. And then I've put here this checklist section down here. I think that's really, really important, to be honest. I think it's very easy for this stuff to get missed when you're doing the ward round and you're running around chasing after the consultant. But this is really, really important. And unfortunately, it does fall to F1s, at least where I've worked, to make sure that this stuff is all sorted. So you want to make sure that VTE is prescribed and documented why you're prescribing it or why you're refusing it. The antibiotics are prescribed and they're continued. Often, I don't know other hospitals, but at the hospital I worked at, we get told off we prescribe antibiotics for more than 3 days without reviewing them. So that's what it means. That unfortunately, it does mean that patients who were meant to be on antibiotics for a long period of time, their antibiotics get stopped accidentally, essentially. So it's really important that we check that every day. Then fluids, particularly if they're not eating and drinking, then we'll be giving them IV fluids. So that's really important to check up on that. And also that whether they're nil by mouth or not. And that's a really big thing in surgery. So there's a lot of reasons why someone might be placed nil by mouth, and they all have slightly different restrictions on what that actually means. So, for example, if someone's nil by mouth awaiting theatre, they can often have medications and tiny sips of water until they actually are sent for theatre, depending on your sort of trust policy. But if someone's nil by mouth because they've got a bowel obstruction, then we normally tend to convert all their oral medication to IV, and would be putting an NG in situ, so an NG in situ. So it varies, and if you're not sure, just ask. Consultants can seem intimidating, and particularly surgeons have a bit of a reputation for being quite intimidating. But if you're not sure, especially when you're new, it's such a good opportunity to ask and say, why is this patient nil by mouth? Because then you can document it and you'll understand what that actually means and how that can affect their management going forward. The other thing is sometimes they're nil by mouth for a scan. So sometimes we'll page the patient nil by mouth for a scan, but then they may not actually, there will need to be nil by mouth so that the scan can be conducted. But it's not so that if the scan comes back, they might need to go to theatre. So that's quite a key distinction, because obviously when they come back, they'll be hungry. And are we awaiting the results of that scan before we can feed them again, essentially? So all of that stuff is really important, and it's on you guys as juniors to document that and make sure that that's getting sorted on the wards. I've put a bit here about common pathologies. I'm not going to go too much into the common pathologies, but generally general surgery. But generally, general surgery consists of upper GI, depending on where you work. Not every hospital has upper GI, HPB, and colorectal. Now, upper GI there's a lot of cancer work. The patients are pretty sick, and there is also some bariatric stuff, but that tends to be in quite big centres. HPB is really common, the sort of standard HPB stuff, so cholecystitis, gallbladder disease, all of that. But and pancreatitis as well is really common. But a lot of the sort of quite more, because HPV cancer requires such big operations, they tend to be in sort of big teaching hospital type centres. So they're not always there, especially if you're in a smaller hospital. But those patients can also be quite unwell. And I think generally the thing with surgery is that the patients can be quite well 1 minute and deteriorate pretty quickly. Whereas I've found in my experience that medical patients, if they're unwell, they tend to sort of get more unwell over time. Whereas I've seen patients, young patients who are very well, doing really well, and then they become much more unwell very quickly. So I think that really is something to think about, and just knowing your pathways for escalation is so important. But I've put this slide on there that if you guys want to go back and have a bit of a read before you start, particularly, if you found out that you're going to be working under a colorectal consultant, then it might be a good idea to just have a look at, what the common procedures are, what common anatomy, and it will honestly go so far if you have just even a bit of knowledge and the willingness to ask questions as well. And obviously appendicitis as well. I've put here about sort of must not miss emergencies, that it's really important to escalate, really. Like, you're never going to be expected to deal with this stuff without, at least some guidance from somewhere else in the hospital. So I think in addition to all the medical emergencies, so MIs and PEs and all of that. So I think that those happen in all surgical patients as well. And the medical teams tend to be pretty supportive, at least where I've worked, with helping out with some of that stuff. But what I would say is these must not miss emergencies. Watch out for your post-op patients. They'll do the ward round, they'll be fine on the ward round because their operation was the day before, or 2 days before. But slowly over the course of a day, between your 8 to 5 normal shift, they can be fine on the ward round and then really unwell by the time you're ready to go home, and they won't have been seen by anyone else. So you've just got to be really wary of this stuff. So in a post-op patient, you want to be really looking out for fever, tachycardia, and hypertension. And I would be really also concerned about severe abdominal pain, because those can all indicate sort of post-op infection, a problem with the surgery, and that can often mean that they might need to return back to theatre. I think the other thing, so I put chest pain and tachypnea in there. I've seen you see quite a lot of patients who develop a PE after surgery, particularly if they've had a cancer operation, or they're maybe a bit older, more frail, not getting out of bed straight away. So all of those things are massive risk factors for the development of PE. So you need to be vigilant. And often, it's very easy for the consultant to come around and be really focused on their operation. The wound looks really good, they're healing well from that point of view, but actually some of these other complications that may be a bit more sort of downstream of what they've done, can be there. And it's really important that you guys are escalating that when you think. And the key thing in this is that it needs early escalation with the potential PE, is that it needs early escalation, because it's going to need to be quite a senior decision about whether you're going to anticoagulate someone, given that they've just had major surgery, most likely. And then monitoring the drain contents as well. So often after surgeries, big drains will get left in. And sometimes they'll have generally they'll have 100 mils, 150 mils, something like that. But sometimes if something's gone really wrong and there's an infection or there's a leak, then you can get really big amounts of contents through the drain. And that's often something that the nurses will escalate to you. And then you'd want to pass that on to your reg or SHO. I think the other things were sort of people to keep an eye on, really. Pancreatitis often gets admitted under general surgery, and unfortunately, pancreatitis patients are very unwell, and it does have quite a high mortality. So you really want to be looking out for those patients, particularly if they start to become very short of breath, very unwell. You want to be, involving your consultant, who will hopefully get ITU involved. And a lot of trusts have a sort of pathway for pancreatitis patients where if they're scoring a certain amount on pancreatitis scores, then they need to get ITU involvement pretty early, because it's known that they have a really big potential for deterioration. And then the other stuff here is mainly about patients that they might be sort of sat on and waited, for example, on a small bowel obstruction that's maybe resolving or could be treated with a conservative management, but then they become much more unwell. So they might become septic or vomiting, and that means that you really want to be escalating that as well. I think the other thing is on the bloods that get sent most days, and a lot of patients on surgery because of the nature of bowel surgery are on replacement of their nutrition through the veins, so TPN. It's really they can get pretty wacky electrolyte abnormalities, so it's really important that you guys are checking up on those using these magnesiums, all of that stuff, and that can also sort of further exacerbate some of these problems as well. And never ignore a severe abdominal pain, even if the nurses are not convinced or anything like that. It's really important that you go and assess, and if you're not sure, you ask someone more senior to assess. I've put on here a bit about this is just my sort of generic rota from my F1. This was my F1 rota at the top, and then this was my SHO or F2 rota. My F1 job was actually trauma and orthopedics, but I did general surgery on call. So all of my on calls were in general surgery, but my my normal ward days were in orthopedics, so I got a bit of experience of them both. And then my F2 job was only in general surgery. You'll notice on my F1 job, I didn't have any nights. It was quite fortunate at the trust that I worked at. They got the F1s were sort of they were removed from nights because they felt that there wasn't a sort of appropriate cover for them at night, but that doesn't tend to be the place everywhere. And generally, I think F1s are pretty well supported. And if you're not, there's so many different channels to raise that. And the reason why we all got taken off nights was because the foundation school, we raised it to the cohorts before us raised it to the foundation school, and therefore that they acted very quickly. So I think the key thing to take away is that the rotas can be quite intense. Like this, the SHO rota was really pretty tough. 1 in 4 weekends with nights and all of this, but I think I personally really loved it. I wanted to do surgery, but I think you can get a lot out of it as well, even if you don't want to do surgery. So I think there's lots to be got out of it as well. I put here about the sort of basics in terms of investigations. I think it's important to know with bloods, particularly in post-op patients, different consultants will want different bloods. Now, so for example, CRPs are really common requested bloods. Some consultants really don't like a day 1 or day 2 CRP because it just sort of adds confusion, because it's going to be raised, and then it's like, how raised is it? Has it gone up massively since before their operation? And then it's like, should we be starting them on antibiotics if they weren't already? So it just adds more confusion. So get to know your consultants, particularly if you're only with one consultant the whole time. Then it's really important that you know what they want and what they like, and that means that your life will be much easier. And as I mentioned earlier, there are a lot of patients on general surgery, particularly that require nutrition through their veins because their gut has been operated on or has a problem with it. So that means that they're getting nutrition that we're essentially adjusting how much electrolytes they have. And that means that it's really important that we're checking those electrolytes every day. So your trust will have a TPN bloods protocol. So that'll be all the bloods that you have to request. And often, at least where I've worked, the dietitians are really good. If you have a chat with them about what the different levels were in the bloods, then they can alter what they give the next day to adjust for that, as long as it's sort of within a reasonable amount, and we don't have to sort of correct something a bit more immediately. Blood cultures will be a thing that you will have to do in pretty much every patient that spikes a temperature and you're worried about sepsis. So get used to doing them. Get used to trying how your trust does them, because they vary. I was the trust where I trained at during medical school in Preston. It was really easy. The bottles that they had was just really much easier to do. But then when I've started in F1, the actual bottles were just a bit more challenging. So when you go for your shadowing days, ask, can I try and take some blood cultures, stuff like that, and get used to some of those stuff, because in August it'll be you guys that's expected to do that, and that sort of thing, being competent with stuff like that really makes a big difference, because it'll just make your life much less stressful. And then amylase is obviously used a lot in our pancreatitis patients. So have a bit of an idea about that. It's quite a common question that the consultants will ask about amylase. How quickly does it peak? When does it come down again? So I think stuff like that it's sort of nice to know. You don't really need to know it, but you just need to know that it'll be requested, and it will be a part of the workup for any patient with suspected pancreatitis. And then I put here about tumour markers. I guess just knowing the common ones for colorectal, pancreatic cancers, and just keeping an eye on them, really. They're often not really requested in the acute setting, but you do get some patients with sort of new diagnoses of cancer where they will request them if the CT is showing something on emission that's then causing a blockage. Oh, sorry. And then I've put here about imaging, basically just saying that CT imaging is pretty much now the mainstay of all general surgical imaging, at least. But there are some cases where CT is not best. So I think particularly for gallbladder and right upper quadrant issues, so cholecystitis, acute cholangitis, and biliary colic, it doesn't work as well, because the CT, often the gallstones don't show up on a CT, so it doesn't give you anything near as much information. It'll show you if the gallbladder is perforated, but it doesn't give you as much information as an ultrasound. So that means that ultrasounds are requested much more for those things. So keep an eye out. Just get a bit of an understanding about when you would request an ultrasound, when you would request a CT, when stuff will show up on CTs as well. And also, I don't know, it'll depend on your trust, but I know that some trusts don't actually allow F1s to sort of request a CT on their own, but where I've worked, they do. So that means that there's quite a lot of speaking to the radiologists, which at first is a pretty daunting experience. Where I've worked, they're a pretty combative bunch, but that's not the case everywhere. So I think the main thing with that is they just want you to have a bit of an understanding of why the imaging is being requested. Just go into them with the idea that the consultant wanted you to wants the scan from the ward round. That's not really enough. So if you're not sure on the ward round, make your life easier rather than having to chase down a consultant who's then operating, by asking when you're on the ward round, documenting it in the notes, and then making sure that then you can speak to the radiologist with a bit more information. And for that as well, I think the main thing is to make sure that you've got all the information in front of you. There's nothing worse than you're on the phone to the consultant radiologist who's busy. They're on call. They're getting hundreds of calls over the course of a day, and you're faffing about trying to find the observations. They're going to ask that stuff. They're going to ask what the most recent CRP is. That. So make sure you can write a brief summary. Sometimes I know I've heard of some people who, if they're doing a referral to like a scary specialty or something like that, they'll write a brief summary on their notes or on their computer that they can sort of refer back to, and that just makes everything much clearer in their head. So when you start, all your summaries will be a bit jumbled up. So it can really help to sort of write everything down, and then it makes it much easier as you go through. And then ERCP and MRCP, I think it's really important to know the difference between the two, why the two might be used. So MRCP is used for the imaging of that's an MR scan of the pancreas, gallbladder, and the surrounding area. And it's really good because it shows the ducts, it shows where any of the stones are, shows the dilatation, can also show any cancers or anything like that. But ERCP is an endoscopic procedure where they directly look at the ducts. They can perform, they can remove stones, they can take out the sphincter, which will enable stones to pass much more easily. And generally, patients tend to have an MRCP before they have an ERCP, but sometimes they go straight from ultrasound to ERCP. So just having a bit of an understanding of that as well. And then knowing your trust sort of endoscopy procedure, how to request it, because it will be different. Sometimes it can be different from the radiology stuff. And then also what investigations and what medications are needed to be addressed before. Your trust will have policies on this. Sometimes they'll want an INR if they're doing any procedure. They'll want to make sure that all their anticoagulants are held for 48 hours or something like that. So, if that is the case and you're holding medications like that and you're not sure about it, don't just follow what the trust policy says because they need to be held. You need to make sure that that's a sort of active decision and that often you want to document that you've spoken to a senior about it, because you don't want to be just wandering around stopping people's anticoagulation or something like that, because then they can get a clot. And then I think sort of special tests that are unique really to general surgery, not quite unique, but the big thing is sort of oral contrast. So that's used a lot if we think that there's a blockage or in the bowel, or if we think that there's a leak from a surgery. So when you've had the surgery and you've got the two loops of bowel that have looped together, sometimes sort of day 2, hopefully maybe not a bit earlier, they can eventually leak, and that can be really bad because the patient will come very unwell. But what you can do to see if that's happening is give the patient a drink of the contrast, which often has to be prescribed, and that'll be a job that you guys will have to do. And then a few hours later, you can do a CT scan or an X-ray to see how far it's passing. If there's a blockage, then you can see it on the X-ray. But if it's an anastomotic leak, often you'll do a CT and you can see the contrast leaking into the abdomen or into a collection around the anastomosis. And that will indicate, that they may need to return to theatre, or the collection may need to be drained. And then ultrasound or CT guided biopsies. I included this because it's often your responsibilities as F1 to make sure that everything's in place for that to happen. So the patient may need to be known by mouth, they may need to have an INR the day before, their anticoagulation may need to be held. So all of that stuff, you need to be checking that, you need to be working out what your trust sort of guidance is on that, and because unfortunately it does vary quite a bit. So if you're not sure, just ask. I think that's my general point and takeaway really. I think I put here, this was sort of basically about what you guys should sort of know and have a bit of an understanding of before you start, which will help you a lot. Then what you should try and do by the end of your rotation, everyone should be trying to do this, whether you want to do general surgery, any surgery or not. And then there's sort of optional or nice to do stuff by the end. I think by the beginning, it's important to have a bit of an understanding about the investigations, what the indications are, when you would use a bit of contrast, when you would not use contrast, stuff like that, having a bit of an understanding of that. But mainly, when different investigations are indicated, why patients might need a certain investigation. So having a think about that, an understanding of the basics between those is really important, I would say. And if you don't feel that confident on that before you start, I would have a bit of a read on that now. I think by the end of your, in the top there, I said, this stuff, it's really easy. Horace and the portfolio as a foundation doctor is basically how you assess as you go through. And it's venipuncture, cannulation, ABGs, stuff like that. You want to get them signed off and documented in your portfolio that you've done it. again, I know you will have been signed off during medical school, but they're really easy to get. It's an SLE that you can then use in your portfolio. And stuff like that is really good to do whilst you're on general surgery, because um, there's a lot of different little procedures, and if you show that you can do stuff like that, then you're much more likely to be able to sort of progress on as well. Then I think by the end I've put here, if you want to get the most out of your job, everyone should be by the end competent in inserting an NG or Riles tube um, for drainage, because that's a big part of everything that we do on general surgery. Pretty much any patient who comes in with a bowel obstruction will have drip and suck, so that's NG tube inserted on free drainage and IV fluids, and their tubes will come out, they'll pull their tubes out, the tubes will slip. It happens all the time. The tubes will become blocked. So changing them, removing them, they're vomiting, all stuff like that is really important that you guys are aware of that and how to do that. So try and get teaching early and practice, practice, practice. If you don't feel confident, get the reg to watch you, get your SHO to watch you. I must have put hundreds of these in whilst I was on general surgery. I think like the most I ever did in a 12-hour shift was probably like 8. So, it's something that's happening all the time. And it's really important that you guys know where all the stuff is, can get it ready. And then, if you want someone more senior to help you, watch you, just ask, because they'll be really happy to, especially at the start. So use the fact that they know you're new and, try and gain from that as well. Then I've put here about removing clips and sutures. Often the nurses tend to do it, but even if you want to do medicine, you have no interest in doing surgery, there will be patients who have sutures or have had sutures or clips following a procedure on medical wards. They'll be everywhere in the hospital. So knowing how to remove them, I think, is a really good thing to know. And also, I think understanding a bit, obviously removing a clip is not a difficult task, but speak to your edge. Why are you taking out alternate clips? Why are you only taking out the clips towards the edge of the wound? Why have you taken out clips at this point? So having a chat with them. Why are we taking them out on day 10, not day 14? Why are we staggering how we're removing the clips? All stuff like that is so valuable. And if you ask questions, any a good senior will really like that and want to give you more teaching. I think a lot of the time, unfortunately, the way medicine is now, it's so busy. Everyone's so busy. Everyone's got their own stuff going on in addition to everything they're doing on the wards. So I think, unfortunately, it used to be that, or at least I've been told that it used to be much more, you'd have structured teaching and you'd be told much more. The ward rounds would be a whole sort of long teaching experience. But now, unfortunately, the way it is, unless you ask, you're not going to get this teaching. So you just need to ask and you will get it. And then I've put here about drain removal. So a lot of these patients will have drains in, they'll often become blocked or they'll stop draining and it's time for the drains to come out. So try and have a go at drain removal. Ask the nurses, can I help with that? Because even if you end up doing medicine, you'll be a med reg, you'll be taking in and taking out and putting in chest drains, which are a lot more scary than an abdominal wall drain that has basically clotted off or is done draining. So getting a bit of experience on that is really important. And then male and female catheters, a lot of patients on surgery are catheterized. Get good at catheterizing patients, because you'll need that skill wherever you go in any acute specialty. You'll be putting catheters in. And then I've put here about sort of optional stuff that would be good to do by the end, but by no means is essential. Having a go at suturing, whether that's just hand tying, practicing your hand ties with someone who's teaching you, or actually doing some suturing, because most of you, if not all, will have an ED job in F2. There'll be cuts, lacerations, everything like that. It's really important that you get a bit of time. I would try for everyone to go to theatre just to see what it's like. They'll get you a bit more involved than you would have been at medical school. So try and push for that if you can. It's not always easy, is the thing I would say about that, particularly in F1. If you have a job in F2, you'll see a lot more of it. And then I've put about abscess drainage as well. That's like a common sort of starter procedure that they tend to be the first thing that a lot of young budding surgeons end up sort of getting asked to do in theatre. A lot of the time, I think the main thing that people are sort of scared about is on calls and holding the bleep. I think for that, a lot of the two photos here sort of show that a lot of systems now. I'm not where I've worked. I'm still on the bottom version, but a lot of places have moved to sort of electronic bleeps now, where all bleeps are electronic, but like online bleeps where you can get a full text report of what's going on, and that can allow prioritization much easier rather than. So I guess the point here is just to get familiar with your hospital's bleep system, know how to bleep someone, know the sort of main numbers to bleep. One good thing is the Switch app. So AccuRx have a Switch app, and for pretty much every hospital in the country, as far as I'm aware, you can put which hospital you work in, and then it has all the hospital directories straight on your phone, and you can just see the numbers that you're going to need to bleep for anaesthetics, for ITU, for the med reg. Stuff like that is so important. And often, at least where I've worked within our team, so within general surgery, it would be quite rare for me to bleep the reg. They would normally, I'd normally have their phone number. So get their numbers early, get their WhatsApps, and give them a call, because they'll answer that quicker often than a bleep. I put here about, don't dismiss any worries in these patients. So post-op patients, the consultants will tend to be pretty, cautious with these patients. They've operated on them. They take quite a lot of pride in making sure that they get out from hospital as well as they can be. So they'll be wanting to keep a really close eye on it, and that will mean that they won't want you to not escalate to them. So if you're worried, speak to the reg, speak to the SHO, and if they're not there, you're not able to get in touch with them, don't be afraid to escalate to a consultant, particularly during working hours as well. And then pancreatitis as well. These patients have quite a big propensity to go off pretty quickly. So, keeping a close eye, making sure that ITU are aware if required, and that your consultant's informed if you're worried about them. And alcohol and opioid withdrawal patients as well. Often that, it's somewhat sidelined or not realized on initial admission, or they might come in really unwell and not able to tell you that they actually have an alcohol dependence or an opioid dependence. And often that means that it can get missed until quite late on, and then they start having quite significant symptoms. And I've seen that on the general surgery ward that I've worked on as well. So, knowing who your teams are for that. Hospitals will often have a dedicated alcohol and opioid withdrawal team who will come around, tell you what to prescribe. They're normally really helpful. So just ask, and once you've done it a few times, you'll feel much more confident. And then there's other stuff is just, during on calls, this is the main majority of all the stuff that you'll get bleeped about. So knowing what the common sort of analgesias are, the step up of that, what the side effects are. So, if someone's in small bowel obstruction, that's semi-resolving, they're in pain, you need to, you'd want to think a bit about giving them loads of opioids. Can we try and reduce the amount of opioids they're being given by giving them some other medication? Have a chat with your seniors if you're not sure about that, particularly when the side effect of a medication is something that you're almost trying to counteract. And then fluids, generally on general surgery, they pretty much always just use Hartmann's for fluid replacement. And I know medicine, they tend to use sodium chloride where I've worked, or normal saline. But yeah, I think that's the main thing really. Just, making sure they're prescribed, particularly in pancreatitis patients. They'll need to be aggressively rehydrated with fluids. They'll lose a lot of fluids. So making sure that, you're giving them as much fluids as they need, but also try not to overload them. So if you're not sure, just ask, get a plan with the fluids, and ask, is particularly at the start. And then another thing is, because of the risk of feeding down an NG tube that's in the wrong place, um, a lot of trusts now have a pretty rigorous, because it's a never event as well. Pretty much every trust now has a very rigorous process for confirming that an NG tube is in a safe position. So you want to you want to make sure that you're familiar with that. If you've put an NG in, document very clearly whether that NG has been checked properly. So there's lots of different ways to do that. Some include a chest X-ray. So there are devices that you can put down the NG to see that whether the contents is bowel or not, is within the gastric contents essentially. Often they rely on pH or something like that, and whether it's safe to feed. And make sure if you've put that in and you're not happy with it, you document that it's not safe to feed, because otherwise, there'll be a serious investigation if it does eventually get fed down. And then the main thing is, often you'll be asked about whether patients are well enough to be discharged. Now, that it's never a decision that you should be making on your own as an F1. So just making sure that you're aware that that isn't a decision that you should be making on your own. You should be speaking to your seniors. If it wasn't the plan from the ward round, say that when you're speaking to the nurse or whoever's bleeping you, but try and escalate it as best as you can, because there's immense pressure on all hospital beds. So if a patient could actually go home and everyone's saying that they're ready to go home, they're keen to go home, then it is important that you try and speak to your reg or your consultant about it. Antibiotic duration, often, you'll be asked, do these antibiotics need to be extended? Are they ready to be finished? Now, again, outside of sort of trust guidelines, this tends to be a consultant decision, and that's why I sort of said to mention it on the ward round, because then every day you've got a documented decision about whether to continue, stop, or start antibiotics. So it's really good that that's such a golden opportunity for you to make sure that you have that available. And then I've got there about VT, making sure that it's prescribed is a big thing as part of being an F1. And obviously verification of death. Unfortunately, patients will die when you're on general surgery. Hopefully, less often, as the patients tend to be younger, given that general surgery tends not to admit patients who are completely inoperable or palliative. They tend to go under the medics, at least where I've worked. So it probably is a less frequent occurrence, I would say. But the first time you do it, I literally just on Geeky Medics, there's a summary, and you can just read exactly what they've written there, and then there's a sort of an example of how you would then document what you've done, and pretty much everyone I know just uses that summary, and it's I think the thing to say with that is it's never really a nice thing to have done. So if you're doing that to Visio on call, make sure afterwards, you take some time, go have a coffee or something like that, just making sure that, you're okay and you're safe to continue your job, because even if it's really busy, just taking 5 minutes to go somewhere away from the ward, have a sit down in the mess or something like that, or in Starbucks, and just making sure that you do take some time to process that, and having a think about it, talk to your colleagues, your partners, everything like that as well, if it does affect you. I've got here some sort of example bleeps that you guys can have a think about. I don't know if you guys wanted to pop some sort of your thinking in the chat as well. I don't know if Rhiannon can see the chat, but yeah. And then have a think about how you would prioritize these and what you would do in response to them as well. Let me try this. Any thoughts about how anyone would prioritize these? Have a think. Okay, I'll just sort of go through my thinking, I guess.
So there's one that's just come through. So Galina said to see the deteriorating patient first, do a full A to E, alert their senior, and give appropriate treatment such as fluids. M agrees to the deterioration patient first, then fluids, then family.
Yeah, yeah, I think that's definitely probably what I would say as well. I think these sort of prioritization questions tend to be, as you go on in your careers, and I know a lot of people have them in their OSCEs now, but they tend to be a big part of medical interviews as well, and also what it'll be like on the actual day. So I think this deterioration post-op, I think generally I would stop pretty much whatever I was doing and go and see that patient. That stuff like dropping their BP and dropping their blood pressure, becoming much more unwell in a patient that's post-op needs to be seen quickly, and they need to be seen by a senior. Now, the problem is sometimes when you're on call, your reg and SHO might be in theatres. So I think is a good, as I said earlier, getting their numbers at the start of the on-call shift is a really good way to making sure that you can contact them as well. But at the same time, if you're really worried about them and they're not picking up their phone, I would give them a bleep as well. The other thing I would say is no, even if you not have no interest in doing surgery, don't want to ever go to theatre. You've never liked going to theatre. You've found it really horrible, whatever. I think the main thing I would say is know where your theatres are, particularly your emergency theatre, and know how to get in. Because this patient, you'd want to be telling someone, and if you bleep them and they're doing another operation, you need to be letting them know. So I would go, you can go to theatres, go have a look, see where the theatre, the emergency theatre is, because they might be doing an appendix in a well patient. It could be the reg, the consultant, and the SHO all doing it because they're doing some teaching, and you're really struggling with this patient on the ward, and it's Saturday. So you can go speak to them. They can probably free someone up. They can tell you what to do initially, but just make sure you've got a lot of information when you go, because they're not going to be able to check. You're not going to be, you don't, the last thing you want to do is then they'll be like, what's his blood pressure? And you don't know it. So, that's again where I'd really recommend making a bit of a summary and stuff like that. And then, yeah, family updates, unfortunately, sometimes do fall to the F1, particularly where I've worked. I've, had some quite significant family conversations. At medical school, it gets talked about as something that's always very consultant led, but I don't think that's always the case. But what I would say is, they're they can they're such an essential part of the job because families are so important to patients. Getting a family on side and making sure that they believe that you're caring for their loved one, you're really engaged with them, is so important. And you, as F1s, often have a bit more time to do that and really understand where their concerns may lie, what they might think about it. So I wouldn't go around willy-nilly doing it, but I think try and sit on a few, get experience of them early, and get a bit more of an understanding of them as well. And then yeah, fluids. You need to give him some fluids and also probably review his abdominal pain as well there. Yeah, so I've put here about the sort of opportunities that you'll have whilst you're on general surgery. I've put here obviously the horror stuff. You're going to have to do that whatever the rotation. That doesn't change. So make sure you do it. Don't think about it for the first couple of weeks because you'll be so tired. You'll be getting used to everything. But after at least 2-3 weeks, I'd start having a look, opening the Horace portfolio. What am I going to need to do? You'll have talks on it during your induction, so having a think about what you can do to start on with that as well. And then you'll need to do reflections as well, so you can do that about anything that you've done during your time. I mean, I don't know. At medical school, I was always like, oh my God, having to do all these reflections for my portfolio was so frustrating. But now I actually really like doing them. I've had throughout the course of your training, you have more difficult cases where something might have gone a bit wrong, and the opportunity to write about them in your portfolio is really valuable. Discuss it with your educational or clinical supervisor, and that's how we sort of develop as doctors as well. So don't treat them as a chore. Try and lean into them because I do actually really think that they help you develop as well. And you'll have supervisor meetings. Try and arrange them as early as possible, and yeah, cover how to escalate the unwell patient as well. I think everyone should try at least to get some theatre time, gain some practical skills, and get involved in audits and QIPs. The surgical units, there's QIPs going on all the time. So get involved, speak to a consultant, speak to a senior, try and get involved. Maybe during F1, speak to one of your SHOs, ask if they're doing any projects or anything like that. And then, nice to do a bit more operative experience, getting involved in research projects, also getting involved in teaching, teaching medical students, designing a bit of a surgical teaching program. This is all sort of nice to do, particularly if you're interested in pursuing a career of surgery. And I think, yeah, if you are considering an application for surgery, make sure you're completing a logbook because by the end I had to go, I was going in on my days off to try and get procedures because I hadn't been keeping up with it through medical school, and I definitely missed some procedures during F1 as well. So, that's quite frustrating when you come to the application deadline and then seek to get involved in audit and QIs early on. 4 months feels like a long time, but honestly, by the time you've got something registered, you've started it, then you've done one cycle, it'll get quite close to the end of your rotation, and sometimes you're then rotating to a different hospital or definitely to a different unit. So it can be quite frustrating sometimes to feel like you've not finished a project or because you didn't quite start it early enough. I put this bit in here just to have, if you guys are thinking about applying for CST, I'm more than happy to have any questions, answer any questions that you guys may have if you want to pop them in the chat, or alternatively, I think I can stay behind at the end a little bit, or Rhiannon can send my email out as well. If you guys have any questions, but maybe don't want to ask them on here as well, I'm more than happy to go through anything that anyone may have or give some advice about that as well. and we've got some other, sort of surgical themed ones as well. If maybe general surgery wasn't quite for you, but yeah. Yeah, I think here, just to say that the jobs are pretty fast paced. Um, they'll feel like a lot at the start, but you'll get used to it. But the really nice thing is that because you're across sort of three departments, it's a big team. Often they'll have, like, at least where I worked, it was the basic, like there were the most F1s on it. So it's really social. It's such a good job to have during F1. Um, Escalation can be tricky, not because the regis don't want to know, but just because there's other stuff that they can be doing where they can't be, they can't actually answer your bleeps because they're operating, they're scrubbed in. So, like I said, know where your theatres are, have a bit of an idea about what you would do if you can't reach your registrar. Can you call the consultant? All of that. Exception reporting has been reformed now, so it's much easier to do, and no one actually from the unit gets to see who's exception reporting. So obviously, that's not me saying just report. You need to be truthful with what you're reporting, but don't be afraid of repercussions for reporting stuff that it is genuine. So make sure you do it. Your trust during induction will explain. They have to explain to you how to do it. So if you're staying late, make sure that you are reporting because you deserve to be paid. And it also means that if the 3 doctors on upper GI are staying late every day for 4 weeks, then it shows that maybe they need a 4th doctor. So that means that you'll get more support. Hopefully, is the idea. And high, yeah, I think that they tend to be pretty busy and high workload. So having your organization is so key as a sort of F1 and throughout your career as a doctor, really. So making sure you're staying organized, and that goes for your sort of life as well. So try and work. When you've got a block of on calls ahead, have a think about, particularly for your first ones, what sort of impact that will have on you. And what sort of impact that will have on you. So, meal prepping, try and maximize your rest. Don't go, if you're on call all week, try and have a bit more of a chilled weekend, stuff like that. And if you're struggling, reach out for support. Your peers will be, it's such a bonding experience going through F1. I've made lots of friends, and you all work together, you all help each other out. So reach out to your peers, reach out to your foundation team. The foundation admin team are always so supportive. Speaking to pretty much every one of my colleagues, and also the people that have worked at different trusts as well. They all say the people who run the foundation program are all so nice. And also speak to your supervisor. If your supervisor isn't the best or doesn't want to know, the trusted consultants, people you've got on well with, will be really helpful, particularly at the very start of your training. And as I've said throughout this talk, it's really okay to ask, particularly for help, or if you don't quite understand something. Yeah, this is just a bit about my top tips. I think a bit of interest and a bit of knowledge of the basics honestly goes so far, and doing the basics right means that they'll be so impressed. And I think often, generally that there tends to be, I think consultants in surgery tend to be a bit more old school with how they operate and do their work. So, the basics really are noticed. Punctuality, often it may seem like they don't notice, they don't care, but they do notice, they do talk about it, stuff like that. Being there on time, ready to go, ready and prepared is so important. And knowing your patients well before handover or before calling someone is really good. You put in what you get out, I think, as well, or what you get out is what you put in. I think, if you put more effort in, you're more engaged, you will get more out. And if you're not sure, just ask. But I think the main thing is, if you do have any interest in surgery, even in just a small amount, I would tell people that you want to do surgery, or you're interested in it, because they'll get you